Bonjour.
Bonjour tout le monde. Mon nom est Louise Potvin. Je suis directrice scientifique du Centre de recherche en santé publique. Ça me fait bien plaisir de vous accueillir ce midi pour notre première conférence midi de notre série hiver 2022. J'en profite d'ailleurs pour vous mettre à l'écran notre programme pour cet hiver. Donc, à partir d'aujourd'hui jusqu'au 24 mai, on va avoir 8 séminaires et j'en profite aussi pour remercier Malek Battal et son comité de valorisation pour nous avoir préparé ce menu. Cette année, pour la série Hiver 2022, on a décidé de mettre en évidence nos chercheurs, ceux que nous avons intégrés au cours des 2 dernières années comme membres réguliers du CReSP. Vous verrez que la relève est là, que les gens sont à développer des programmes de recherche qui sont à la fois éminemment pertinents et très intéressants. Donc, je vous rappelle que nous diffusons à la fois sur Zoom et sur YouTube. Donc, les gens sur Zoom, vous pourrez utiliser le chat et de même que les gens sur YouTube pourraient utiliser le chat pour poser des questions. Elles seront acheminées vers notre conférencière. Donc, sans plus attendre, je vous présente Lubna Daraz, qui est professeure au département de bibliothéconomie et des sciences de l'information à la Faculté des arts de l'Université de Montréal. Je vous demanderai à tout le monde de fermer vos caméras et vos micros. Donc, à la Faculté des arts de l'Université de Montréal, elle a joint le CReSP depuis 6 mois. Et son programme, effectivement, porte sur les transferts de connaissances et l'information sur lesquels les gens peuvent prendre des décisions. On l'a vu avec la pandémie actuelle que ce n'est pas l'information qui manque, c'est la diversité, la qualité qui, quelquefois, pose problème. Donc, aujourd'hui, on va parler de le Digital Mishealth Information for the Vulnerable Population, a Gold Standard Approach. Donc, pendant à peu près 40 minutes, Mme Daraz va faire sa présentation et après, on reviendra pour une discussion. Lubna?
Bonjour, merci pour la belle présentation, Louise. Je suis anglophone, mais je prends le français. Je parle le français un peu. So maintenant, je vais passer à l'anglais. So I will do my talk in English. If anyone has any trouble understanding me, I'll be happy to discuss later on, and I'll try to speak as slow as possible. And thank you everyone for being here today. Let me see. So thank you, Louise, for the introduction. I just want to go through a little bit more, add a little bit more about myself. So the purpose of today's presentation is to introduce myself and my program of research to the CReSP community and an open invitation for collaboration with me and with my work. I have joined University of Montreal in June 2020. Before joining the university, I was an assistant professor of medicine at Mayo Clinic in the United States. I was also a research fellow at Mayo Clinic Evidence-Based Practice Research Program for 4 years. And I have completed all of my studies in Canada, starting with a undergraduate degree from York University And then I did my master's in information studies from the University of Toronto, followed by my doctoral work at McMaster University Faculty of Health Sciences. I have also completed a postdoctoral training at McMaster School of Epidemiology and Biostatistics. Here is my website. If you're interested to know more about me and my work, I invite you to visit my website. Before I start, so as I said, this talk is about to introduce myself and my work. I would like to open a conversation with the CReSP community for Canada. And my goal is to basically empower individuals with credible knowledge that will improve their quality of life and reduce disparities in health equity, and also to reduce resource waste in Canada. Before I start, I would like to ask if anyone would like to talk about how do you feel based on your experience, research experience, or personal experience in Canada, where do you think Canada stands in terms of the quality of healthcare compared to other wealthy or developed countries in the world? Is there anyone has any idea? I'm sure you have more knowledge, but where do you think we stand? How is our quality of healthcare in Canada? Anyone? No one? Okay. Let's see if I can. So based on this report, which was done, of course, in 2017, and I do not expect that this has improved since 2017, the survey was done among 11 wealthiest countries in the world, and Canada was among them in terms of the health system performance. And this was done in Australia, Canada, France, Germany, the Netherlands, New Zealand, Norway, Sweden, Switzerland, the United Kingdom, and the United States. And as you can see, in terms of health system performance, Canada ranks as one of the low performing country. And this is a very interesting figure. As you can you see, Canada ranks 9 in overall ranking in terms of quality. And for me, is most important is these three: the access to healthcare and also the equity in healthcare. So for access to healthcare, we basically rank the lowest in among those 11 countries, and equity is 9. So basically, as you can see, our ranking is not very good on those specific areas that I'm most interested to work to know. Here is another figure of, but as you can see, compared to those other countries, Canada spends a lot of money really in healthcare. However, our ranking is pretty low. So when you see this figure compared to spending, so Canada ranks again one of the lowest 3 countries among those, despite of spending a lot of money. I do not know if any of you know how much money we spend in Canada for healthcare. Of course, it is in billion. I have a small number from 2019. Of course, this number has increased in 2021, and of course now because of COVID-19. However, in 2019, it was expected to be almost $266 billion, a 4.3% rise in healthcare cost. And from this $267 billion, about 40 to 47 or 49, almost like close to half of the budget really goes to R&D in healthcare in Canada. But as you can see, despite of spending a lot of money in healthcare and also in healthcare research, we still rank pretty low. The quality of healthcare is not very good in Canada. So just to give you some example, there are many examples. What is happening really? Why, despite of spending almost more than 40% of the budget, healthcare budget to healthcare research in Canada, why our healthcare quality is not very good? one of the reasons I am interested to know, coming from knowledge translation and implementation science background, is, as you can see here, just a few examples, like 40% of patients who do not get treatments of proven effectiveness. About 25% patients get care that is not really needed and potentially harmful for them. And 30% of cancer outcome can be improved with the knowledge that the evidence-based knowledge, what is already being known in the literature, in the evidence. And 10% reduction in cancer mortality can be achieved through use of existing state-of-the-art therapies. So basically, high-quality evidence is not consistently applied in practice. So we are spending, like, researchers like us. I'm not of course, a clinician. I do not do research in clinical area. However, as you can see, the researcher who dedicate their lives to do so much of research is not really being consistently applied to improve patient care. And it is a well-known fact that it takes almost 17 years to, translate a scientific discovery to patient care. And that is why in Canada, knowledge translation, in the United States, in Europe, implementation science has become a very hot topic in research community, that to reduce the resource waste, the knowledge translation could be one of the answer. I am sure many of you applied to CIHR, Canadian Institute of Health Research, grant funding, and one of the major components, the CIHR asked us to, okay, what is our plan? How are we going to translate the evidence that we produce from our research so that can be readily applicable to our targeted population? So again, knowledge translation could be one of the answers at the moment. Do we produce more research? Because as I said, like, it takes almost 17 years to translate that knowledge to patient bedside. But you can imagine that after the 17 years, when we are ready, when that evidence is ready to apply to patient care, it no longer can be applicable. So for example, the context may be changed. So those discoveries will be outdated. So you need to do more research. So this is one of the reasons. I'm not saying this is the only reason. This could be one of the reasons that we're wasting a lot of resources, and knowledge translation could be the answer. And again, in Canada, I come from the United States, the implementation science is becoming more and more upfront in research, though I believe, my personal experience, I was in Canada, I was in the state, now I come back to Canada. So I have been able to see the difference in where do we stand. Again, after being in the state and coming back to Canada again, this is my personal feeling, I feel that we are still pretty slow in adopting the knowledge translation in a concept and theories in our work. I see in the state, a lot of initiatives are going on in implementation science. One of my paper will be coming out soon. It's a theory paper where I try to argue that in implementation science and knowledge translation, many people say they are the same thing, but I say it's not the same thing. So I will wait until my theory paper comes out for you to read. However, in Canada, as I said, I feel that we are pretty behind, just to compare to the United States. For example, I have seen many faculty positions are being open in the United States for implementation scientists. And Canada, I have not seen, have seen one or two that health sciences faculty are really recruiting, or even in a school of public health, recruiting knowledge translation scientists or experts. Of course, yes, many of us, we say that, yes, we are knowledge translation expert. However, there is a very few scientists that are being recruited just having the expertise in knowledge translation. So I think Canada is behind, and the policymakers and the institution needs to pay more focus on this area. So now switch our focus back to the patients and the public, where my main focus is at the moment. So what are the patients and the public need? What are their needs and preferences? I'm talking about in terms of health information, because this is all my expertise. I have been working last 15 years in this area, studying the health information needs and preferences of patients and the public, specifically focusing on the vulnerable population. And by vulnerable population, I meant women with different kind of background. So that is my target population I'm working on. After I finished my master's from University of Toronto, this is where my journey really began. I took a reading course. I wanted to know what is in the literature about in terms of health literacy, about vulnerable population, and I saw a huge gap in there. This is where I dedicate basically my life, my career, my research. I want to do something, contribute in the science in this area. But before getting to that, I just want to give you a little bit of statistics again. The numbers, speaks for itself. So in Canada, as you can see, almost 88% seniors are not health literate. 12 million working age Canadians lack the minimum level of health literacy. And it has been shown in the scientific evidence that Canadians with lowest literacy skills have poor health than 3 times more than those with highest skills. And in the state, poor health literacy costs between $106 to $238 billion, and in Canada it's $9 billion. As you can see, this is a bit old number. I'm sure by 2022 the number is very high than $9 billion per year. But of course, even though if it is $9 billion, you can imagine that how much money is really being wasted for poor health literacy in Canada. Now I'm slowly, moving my direction to the online health information. So this is basically the area I work on. In Canada, more than 80% of individuals, they go online to access health information. And as you can see, this is again all number. The numbers is very high right now, especially after the COVID. On Google, I'm sure this number is probably 20 million per day. The people search for health information on Google alone for health information for almost like 7 billion searches. And among those people, 35% of patients who go online for medical information who do not visit their physicians or their healthcare providers to clarify the information accuracy or the credibility of the information they find online. And in the United States, 85 million internet users take online health advice without assessing the quality of the content. Unfortunately, I was not able to find numbers. Again, I have told you for many of these numbers, we cannot find it for Canada. So basically, there have not been enough research being done in this area in Canada. That's why, to support my research, I always have to go back to beyond Canada to support my work, because Canada really lacks research in this area. So that 85 million internet users in Canada, I'm predicting the numbers will be similar, who go online to access health information. They do not assess because they do not have the knowledge and skills how to assess the quality of online content. Billions of dollars are wasted really on unproven therapies and deceptive cures that cause delay in the evidence-based treatments. In addition to poor readability of the online health information, non-evidence-based and biased information due to the writers and sponsors of financial and intellectual conflict of interest is huge up there. So that's why it is very difficult for patients or general consumers to really distinguish between what is really credible information and what is not credible information. So as I said earlier, that I dedicate my life to really contributing the science in this area. I'm working towards developing evidence-based interventions to help patients and the consumers access credible health information online. And of course, again, I want to target the policymakers or health information producers who disseminate health information online for the general public. They also need to and they should follow a quality standard before they post or disseminate any health information for general public. And we'll talk more about the COVID-19, as you all know, due to the massive distribution of misinformation, disinformation, conspiracy theory, the public health providers, the governments, the clinicians are really struggling to save people's life. And this is a very major issue at the moment. So before I get into my program of research, this is some of the preliminary work I did when I was at Mayo Clinic, Evidence-Based Practice Center. The center I was in, it specializes in systematic reviews. So we have completed 2 major systematic reviews. I wanted to see what was the current state of the evidence in terms of the quality and readability of online health information. And of course, this was basically my doctoral work. I completed my doctoral work in 2011. And as you can see, this systematic reviews was completed in 2019 and 2018. And after 8 or 7 years, 9 years, the situation is the same. I was surprised to see the situation of online health information has not changed in after I finished my doctoral work. So the quality of online health information that I found was poor, and the readability of online health information that based on this systematic reviews, we found an individual need at least grade 12 or higher level of education, for example, college or university level of level of education to understand the information that are being disseminated through different online platforms. So based on that work, I have my program of research has 2 axes. Like one, this is the current one that I'm working on. I have received a, if somebody can, I'm sorry, Patricia, if you can let me know the time, I will appreciate it. Thank you. So I have received a Sharp grant to continue my work. So from those systematic reviews, we found, you should also know that there are also tools and frameworks, questionnaire, many things are also available. Many organizations, many individuals, researchers also have developed tools for consumers and patients to evaluate online health information. However, my investigation, we have seen that many of the tools, they include numerous criteria. You may find tools, for example, with more than 99 questionnaires. So you cannot expect a consumer and an individual with low level of education to really answer the 90 questions to really understand, to evaluate online health information. So this is a major gap in those existing tools. They're also not user-friendly. The language they use is very high level. You need high level of education to understand the questions that are posted in these tools. Also, another major barrier is majority of the tools are not validated by general consumers or patients. So my project is addressing this gap in the literature. We are also following the recommendation from American Medical Association and National Library of Medicine that recommends that anyone wants to disseminate any health information for general public, the content needs to be grade 6 or below. But again, my research has shown that an individual need at least a grade 12 or higher level of education to understand that information. So as you can see, there is a huge gap in there. So at the moment, we have finished the content analysis of existing selected tools. And based on those content analysis, I am developing a quality benchmark, which will be validated by patients, consumers, health information providers, and policymakers. Will also include a selected group of a small number of clinicians also to validate those quality benchmark in the summer. And after that, I plan on developing a quality guideline. I also have some good experience of developing guidelines for patients. While I was at Mayo Clinic, I was part of developing major clinical practice guidelines for sickle cell disease. I am a co-author of one of the clinical guidelines. So I'm going to use my knowledge from there to develop, of course, this will be patient-friendly, consumer-friendly quality guideline. Of course, I cannot discuss the details of this intervention until I'm done with this work. So again, based on the quality benchmark that we are developing right now, so I will develop a quality guideline. Also, as I have mentioned earlier, it is very important to also influence or change the behavior of health information providers, especially for social media platform developers. So we will also develop a policy framework, and I'm hoping that I'll be able to somehow network with public health policymakers, government policymakers, so they can make it a mandatory for anyone, at least in Canada. We will start with in Canada, anyone who wants to, even if it is a university. For example, I have evaluated the readability of the health information provided by Mayo Clinic. It was also not good. Even the patient from Mayo Clinic, they need a higher level of education to understand. So I'm hoping that the government or policymakers will make it a mandatory for anyone in Canada who wants to disseminate any health information for the general public. They follow the quality standard. And of course, I have a good sound knowledge in implementation science, just being in the United States for 4 years. I carry that knowledge in Canada at University of Montreal. So I will be developing dissemination and implementation strategies to widely disseminate these interventions in the future. Anyone has any question for me? Or should I answer them later on?
You still have 10 minutes to present, a little over 10 minutes, Lubna.
Thank you.
I think you should be finishing your presentation, and then we'll go with the questions.
Sure. Thank you very much, Louise and Patricia. So this is an example. This is, I have just finished developing 2 user guides, but these are not for patients and the public. This is with my team from Mayo Clinic. We have developed and published 2 user guides for clinicians. And this is, again, there's a very first user guide for clinicians to how they can, even the clinicians, a tool for them, how they can evaluate health information on social media platforms, because their patients are going in Canada than in the USA. The numbers are more high, like 90+% patients, they go online to access health information. And they also need a tool because their patients are going online all the time. You cannot stop them. So we need we felt like clinicians also be ready with some kind of tool so they know quickly how to evaluate the information on online, especially we focused on YouTube here. However, this is again another gold standard that will be, I'm hoping to work on also with my team in Mayo Clinic. So the user guide that I am hoping to develop for the patient would be similar to this user guide. If you're interested, they are available in PubMed. Looks like I cannot. Okay, so I have just published this protocol, and I'm encouraging you and inviting everyone to use it as a gold standard. As I have told you, there's for patients or the consumer, there's nothing like it, at least from my research, the last 15 years of research, there is no structured way to develop intervention, especially for patients and the consumers in terms of digital on health information. So I have published this protocol for anyone who is interested to develop similar interventions to use my protocol as a gold standard for other targeted population or patient population. Again, this is open access. You're more than welcome to read it through, and I'll be happy to provide you with the full text article. And finally, this is the axis 2 of my program of research. I'm very initial stage of this work, as I told you, because I'm very much interested to know digital health information and how I can facilitate access to credible online health information because COVID-19 came. So I would like to also contribute in this area. So based on that, my team has just completed a rapid systematic review. I'll present the data very quickly since I do not have much time. So we have completed a rapid systematic review to understand the current state of the evidence of addressing issues relevant to COVID-19 and health information. And we have just completed data synthesis for the first 3 questions. Last 4, as you can see, I'm really interested to know about the relationship between conspiracy theory and misinformation. That work is still going on. However, we did find some very interesting finding, and my paper will be coming out hopefully soon this year. I'll just present you with very quickly some data from this work from COVID-19. So we have included 135 studies, and we wanted to know, of course, my interest is due to the characteristic of COVID-19, we know that 100% of people, especially in industrialized country like Canada and the USA, they are going online. So I wanted to know where exactly people are accessing their information relevant to COVID-19. And as you can see, majority of the 76% of the studies reported that people use social media platforms to access information relevant to COVID-19. And Twitter, YouTube, Facebook, and Instagram are being used more frequently by the consumers to access information relevant to COVID-19. I was very interested to know what are the content areas that are being reported in the literature, what are the content areas people want to know. And again, due to the characteristics of COVID-19, people really wanted to know anything and everything about COVID-19 so that they can understand, they can manage this condition, right? There is a lot of conspiracy theory, there are misinformation going around. So people really wanted to know credible information. As you can see, the studies also reported about different kind of information sources, which are shown in figure 1. Studies did talk about misinformation and conspiracy theory. As I have mentioned, my paper will be coming out soon. We did found some relationship between conspiracy theory and misinformation, disinformation. There are only few studies did talk about trust in the information sources, but however, again, as you can see in the evidence, I was saddened to see that only a very few studies did talk about the credibility of the online health information. So again, as you can see, there is a consistent gap in the literature. I am addressing this area, which is very important for our vulnerable population. And finally, we have done a subgroup analysis. I was interested to see the content areas, the studies that publish from different contents, what are the content areas they are focusing on. And again, North America, Asia, and Europe. They focused more on the content areas that we have identified, which is consistent with the epidemiology of the coronavirus. And finally, again, currently I am developing protocol, actually almost done, but of course I need more work in that. And this is the place where I'm sending my invitation to all of you. If you're interested in this work, I'll be happy to collaborate. I'm in the midst of writing grant proposals. So basically this will be an international project involving several countries. And the focus of this project will be to understand the online health information seeking experiences of people during COVID-19. I would like to know anything about, what are the content areas, the resources, sources they use, their needs and preferences, how they would like to see the information that are being published on. Especially, I'll be focusing on social media platforms because 76% studies reported that majority of the people are using different social media platforms. And this work will I will not get too much into this. However, the data we collect from those studies, and also I have partnered with Mayo Clinic, Evidence-Based Practice Center, and they will share their clinical data with me, which I will use to develop a digital repository system. And the purpose of this, again, I want to develop a digital repository for especially focusing on the vulnerable population from who can access credible information from anywhere from the world. And I'm using COVID-19 as a case study. However, this repository will be, again, this will be a gold standard. It will be a framework. It can be used to develop other credible knowledge management system for other major crises, for example, natural disaster or political unrest. Of course, I will develop this for Canada at the moment. However, eventually I would like to disseminate this framework for anyone who wants to use it internationally. And because again, I have a lot of experience in implementation and dissemination science, so I will be developing dissemination and implementation strategies. So from this repository, we'll be developing multiple interventions so that the public can access credible health information. So basically, as you can see, both of my research project, really, I want to bring in the public, the patients, anyone who is with a low level of health literacy. I want to bring them to this repository. I'll be developing also website, a searchable website, accessible by everyone, anyone. There, everything will be open access so that people have a platform to access credible online health information. I know this is a very highly ambitious project. However, as I told you, I dedicate basically my lifelong work into this. And of course, Canada, I feel like Canada and University of Montreal, and given Quebec is a leader in AI, I feel like this is the best platform for me to establish this work. With this, I think I will just finish. Thank you very much. If you have any questions, I'll be happy to answer it. And basically, this will be a discussion for all of you and an invitation for network. I'll be happy to collaborate after my presentation if you have any further questions. Thank you very much for listening.
Thank you very much, Lubna. Maybe you could stop sharing your screen so we will have a better idea of who's there. So thank you very much for this fascinating work and fascinating foray into the world of information, which we are all concerned with. Now there are two ways of interacting with various ways. So if you're on the YouTube channel, you can use the chat. Someone is monitoring it. You could also use the chat of the Zoom, or you can raise your hand. So whatever. I'll break the ice. When we're discussing online information, and of course, online is everything from junk to quality. So some of the websites are very high quality. We did produce à CReSP, le CReSP répond à vos questions. We're still producing it, and we believe that we're a credible source. Is there a way in which people can navigate, at least intuitively, into, oh, this is a good source, this is not a good source? Are there ways to assess that and criteria that could be disseminated that people would know how to do it?
Yes, so I am going to share one thing. So to answer your questions, say for example, somebody search for COVID-19 on Google. Of course, many websites, probably Mayo Clinic, one of the first one always shows up. Maybe CReSP will come up. Maybe we publish something through CReSP about COVID-19. So unless, as I have told you, like people, the consumers really do not have the tools in their hand to tell, like, okay, this is a credible source. For example, for me, probably I am a little bit more knowledgeable. So I always check the source, who is producing this information. So these are one of the criteria, who is the authorship. So I go and see, are there really clinicians behind the scene, like really producing this information? What is this organization about? Is this what are the sponsorship? Many of the websites you will see there is sponsorship. So as a general consumer, it is very difficult for them. So they will take anything, so also the studies have shown that people really do not look beyond the first 3 pages of Google search. Many of the people even do not go to the second page. So whatever comes up in the first page, so they'll go and check it. I have also found there is an individual. So he suffered from cancer, he was going through cancer, and he was providing guidance to people in his personal website how to treat cancer himself. So as you can see, this could be very dangerous for somebody without any healthcare provider. So there are criteria. So this is the area I'm working on. So we are developing their criteria, for example, as I said, credibility, then privacy and confidentiality, then usefulness, then usability, then credibility. And credibility means there are many things here. For example, one of this is this evidence-based information they are providing. So for general consumers, to answer your questions, there is no readily available tools are available. So one of the tools that are being widely used is Discern. I want to show you how this tool looks like. And you cannot expect Discern. I will share my screen again so you can see how the Discern looks like. Though this was not developed for online health information, but for evaluating health information both by consumers. And I want to show you the tool, how it looks like. So see, for example, and again, this tool is not readily or easily accessible by the consumers. Nobody knows, the consumer doesn't know that these tools are available. So of course, when I develop my own tool, so that will be, we'll find a dissemination and implementation strategy so that people know when they search on Google. I am also thinking about to, add in. So for example, when you go on Google, so this tool, my tool will pop up on the right side and they'll quickly able to evaluate. So again, until I publish it, I will not be able to say it more, but here is the tool, for example, one is available for patients. So as you can see, how can you expect a general consumer to use this tool when they're searching for health information and then say, okay, this source is really credible. So you see, they have to read all of this, they have to make sense of it. If the answer is no, then go to question 3, impossible. As you can see, and you can see how many questions, and the readability is very high. So in the end, so there, as you can see, this is one of the few of the tools that are available. So again, to answer your questions, so they have to go through this entire tool to really at the finally, the low, moderate, and high. Okay, then that after they are able to really score the website, then no, there is no way, you cannot expect. So this is just one quick example. There are many tools available, but there's nothing readily available for the consumers at the moment.
Thank you. Is there another question? Someone raising their hands from, yes, Madame Amel.
Hi, thank you, Dr. Daraz, for your presentation. It was really interesting.
Thank you.
I'm working on the influence of industry on nutrition professional nutrition professionals. And I wonder if your tools maybe one day could be adapted for professionals as well, because we know we have a lot of information. We are confronted in front of information from industry, from different sources. So maybe I see your tools and maybe I see something for professionals as well that are lacking time to maybe do this work to evaluate the credibility of the study. So I want to hear you on this.
It's very good. Thank you. Very good question. So this was the purpose for me to present my work. And again, I was just talking to Louise that hopefully by end of this year, my tool will be developed and then I will disseminate it. And yes, as I said, I am developing this tool as a gold standard. So anybody can really customize it to their the need of their stakeholders. So that's how I'm putting a lot of work in it, so that can be replicable and customized to your personal audience. So yes, so again, because we are involving different kind of patients and public to develop the tool, so that will reflect the needs and preferences of different kind of users, so that the diverse preferences are implemented in the tool. So yes, definitely you'll be able to use it for sure. And please communicate with me. I'll be happy to share the tool with you once it's.
There's a related question from the YouTube channel. It's
yes.
Kathy Nguyen asking, how should the benchmark be used by healthcare providers or even the educational field during the training of future healthcare professionals?
So I have showed you 2 examples of the user guides that we just published. So those user guides would be more applicable to your question, Kathy. And those articles are open access. You should be able to use them. If not, please feel free to discuss with me. But again, yes, those user guide for clinician we develop mostly based on YouTube. So you just hit the point. So that can be used by clinicians who use YouTube to search for health information for their clientele. And my benchmark can be used also by healthcare providers to train them, because many clinicians, they do not know how to really guide their patients' population to access the online health information. So when you train the healthcare professionals, as I said, my tool will be probably maximum 5 questions, very easy to read, very easy to understand, very easy to use those questions. It's not going to be 10 or 15 questions. So in your training in healthcare professional, when they are aware of this tool, of this benchmark, so they will be able to, in their encounter with their healthcare professional, here is a tool, because either we like it or not, everybody is going online. So the dissemination strategies will be implementing as much as possible. Any clinics, hospitals, healthcare organizations, universities will be disseminating our tools to encourage them to use this tool for their patients. So again, yes, so it could be easily applicable. So this benchmark, as I said, this can be also applicable for YouTube as well, any kind of digital platforms. Thank you, Kathy, for your question.
Are there other questions? People raising their hand or on the YouTube channel? In the meanwhile, I do have a question. We do have a lot of pressure towards the open science and open access, and to publish open access. Is there any evidence that there's a relationship between open access science and open science and the acceleration of the quality of the information available on the web?
This is an important point. We have just, I have been discussing with the different team members from especially from the US about, publishing something as an open access. So the repository, I'm sure you have noticed that I have mentioned that repository that I will be developing and the intervention I will be developing, I would like them to be open access, so that the consumers can access it and use it. At the moment, as I told you, there are tools available, but for consumer, there is no way for them to know where they are, how to access them, how to use them. So yes, the open access, I am for open access. And for us scientists, it is very difficult when I'm struggling with, this is just something really frustrates me. You have to pay so much money on these high impact journals to publish your work, and who is accessing them? Only the scientific community, because as I told you, my lifelong goal is for the patients and consumer to access our work. So that, because as I told you, in Canada, we are spending so much money, but the quality of care is, the ranking is really low. Of course, as a Canadian, I would like to see it go up. So what we can do, like from my expertise, what I can do, like help consumers, the patient, to access credible health information so that they can self-manage their conditions. So to do that, I have to be able to, find a platform that will disseminate my intervention, my work, like freely for everyone. So some say no, it's not a good idea. Some say good, especially the journals, the high impact journals are becoming so much political in publishing. They are not for it. So it's a political debate at the moment. But however, my intention is that's why I need the policymaker granting agencies support so that I can disseminate them on a platform. But again, of course, when I disseminate my interventions, my work through open access platforms, of course, we'll make sure the quality is, it's not like just their quality is maintained. So of course, we have to ensure that as well. I think there's some questions there.
Yes, again from Kathy Nguyen. Do you think that government bodies should regulate the information regarding healthcare and maybe even assign an official seal of approval?
Yes, so I have mentioned that there is one, it's called HON Code of Conduct. And so so again, for example, I believe you have to purchase it. If they encourage the HON Code of Conduct, they encourage people or many organizations to have their seal. There is something is available. Again, one of the tools that we evaluated is HON Code of Conduct, and it's been used by many organizations as well. However, it is not widely used and it has some limitations as well. But again, as I said, like after I finished developing the benchmark and the policy framework will be for the health information providers. And I think, and it's not like they should, I think government in Canada must regulate this, like how the health information is being disseminated on online platforms. And there should be, yes, an official seal of approval. So that would be that's why I'm reaching out to CReSP community to, come in hand with me, because I alone cannot do it. As a group, as a community, I think we need to really convince the government policymakers that there should be something like, and as I said, it's a very challenging work for me. It took me 15 years to come to this point, to really, it's almost like the sell in the idea, this work is so much important. I showed you the huge research gap in there, and really nobody's paying attention to that. So yes, one day I hope from here, from Quebec, from University of Montreal, we come up with something like that, starting with the Quebec government, hopefully. Thank you, Kathy, for very, very good questions. Thank you.
Are there any other questions?
Or discussions?
Or comments or...
Yes, comments. I really love to, as I've mentioned, I'm applying for grants. Louise knows about it, and I'm really looking forward to collaborating. If you have knowledge and expertise in some of this area, I would be happy to really bring you on board as a co-applicant on my grants. And I would love to do, and I know I'm Quebec in Montreal, I'm very new. I do not know almost no one. So I'm really looking forward to working with all of you and in the CReSP who have a mutual interest in this area of work.
There's a question asking if you're, Andréane Tardy was asking if you're planning to translate your tool in different languages when ready.
Yes, of course. So I'm starting with English and French. And then as I have told you, like I want anyone from anywhere from the world to be able to, because I'm developing as a gold standard, so it has to be in different language. I come from Bangladesh. Obviously, I want my people to use this tool because in Bangladesh, they do not have very good healthcare system like Canada. So this tool will help them. But Bangladesh is very advanced in IT. Everybody goes online right now. So yes, it will be translated in different languages for sure. Yes, starting with French and English, of course. Thank you for the question.
So I think we will end here. Thank you very much, Lubna, for a very good presentation and an area of work that we're not necessarily all aware of. So thank you very much. Good luck in your career here at the Université de Montréal and at the CReSP. There's one new message. Okay. And I remind the others that if you want to contact Lubna, it's easy to find on our website. And our next presentation is February the 21st by Bilkis Bisanji and her group from the School of Nursing. And the title will be L'application de l'analyse comparative entre les sexes pour faire progresser l'équité, la diversité et l'inclusion à l'Agence de santé publique du Canada. Donc, Bilkis qui est ici et qui va nous joindre comme conférencière le 21 février. Donc, à la prochaine et d'ici là, ben, essayez d'éviter la COVID. Merci.
Thank you, Louise.